I'm Dr. Jennifer Jackson. I'm a registered nurse and assistant professor in the Faculty of Nursing at the University of Calgary. And this video is looking at examples of quantitative designs. So let's see if I can get the Zoom machine to work. So we looked through this chart and we saw how we ask questions about what kind of design. We've got a study in front of us and we can figure out what kind of design we expect. So now what are examples of these different designs? So we're going to start on the green or the right-hand side, your right-hand side. So the descriptive designs. So descriptive designs document what is happening out in the world, and you describe relationships between variables rather than trying to predict or trying to change those relationships. You measure what's existing. So you often do this with surveys, interviews, observations. So maybe something like, okay, if an election was held tomorrow, how are you going to vote? That is a descriptive design. You're not trying to change anybody's vote. You're just trying to say, if you voted tomorrow, how would you vote? And then what relative amounts of votes for each candidate do we have? And are those related to gender? Are they related to socioeconomic status? And so on. So a typical descriptive study, so prevalence, which is often used to measure disease burden in a given population. So we're looking at the example here, depression and anxiety prevalence among nurses during the COVID-19 pandemic. So we look at, okay, we're in the context of the pandemic, what are the rates of depression and anxiety among nurses? So it's quite straightforward in terms of design, but it's also extremely valuable to tell us how is our nursing staff doing in this context. It's also good to know that prevalence designs, at least something like this, relatively speaking, this is going to be a more straightforward type of research to do. It doesn't mean it's easy, but it's a little bit more straightforward because we're assessing how much of the thing is out there. So you'll see when we get into experimental designs, it becomes more and more complicated, which makes it less feasible. But here, these are very feasible, and they're a really good research tool to tell us how much is out there. Because if we know we have high rates of depression and anxiety, hopefully we're going to do something about it so that we can support those nursing staff in that context. Next type of descriptive studies are longitudinal. So this is when we look at what happens to a group of people over time. This could be something we measure every week, we measure every month, or we measure years and for many years. So we collect data from often a group of people over an extended period. So we're looking at the impact of mental health and working in healthcare. And we want to look at, okay, how does it compare to, say, the beginning of your career with 5 years in, after you've gotten over the transition period of being a new nurse. We could also look and say, you got a cancer medication, how are you doing now, 3-5 years later, and look at outcomes over time. So it's not a single measurement, it's multiple measurements, but the same population and the same variables. So we're always measuring the people who got that specific cancer medication. So cross-sectional design is so called because we look at a cross-section of society. So if we think of cross-section as the scientific term, is like essentially we take a slice of something, we take a slice of our population, we take a group that is representative of everybody, and we look at different variables within that group in a population of interest. So we might look at, staffing. This is Linda Aiken's hallmark study of staffing, patient mortality, burnout, and job satisfaction. So at one point in time, she measured outcomes for nurses and found that when nurses are short-staffed, patient mortality goes up, burnout goes up, and job dissatisfaction goes up. So she looked at the relationship between those variables at one point in time. And when I say one point in time, I generally don't mean like on a single day at 11 o'clock. I mean that they collected data across, say, 30 days or across 3 months. And then use that information because relatively speaking, that is considered the same time, unless you have very, very sensitive variables, in which case you're beyond an introductory cross-sectional study. So here we know the directionality of the relationship. The staffing is connecting with the patient mortality. Patient mortality is not influencing staffing. We know which order the variables are happening so that we know how to like order that relationship in our minds. However, then we have the correlational design. Now, cross-sectional and correlational studies both assess the relationships between variables. Cross-sectional studies have directionality, correlational studies don't. So, does having your camera on in class associate with better grades? Well, we don't know if having your camera on means you're a keen student and you're paying attention and you're writing notes and asking questions and that gives you better grades. Or do you have better grades and so you're more confident and so you're turning your camera on in class because you're just hanging out and you don't have to think twice about it. Is exercise associated with mental wellness? Well, it might be that exercise improves your mental wellness, but it also might be that if you have better wellness, you have more capacity to exercise. So we know that they're related, but we don't necessarily know the direction of the relationship. And likely the direction of the relationship is complicated. Like it's probably a little bit of this and a little bit of that, and it's all connected. But this association can be valuable for us because it can tell us we can do more work to understand that kind of thing. Or we might be aware that, okay, if we're seeing this one kind of variable, we can anticipate that another kind of variable might also be coming into the mix. So correlational study, we look at staffing and pressure ulcers. So when we have negative correlations, so low rates of staffing, we're going to have high rates of pressure ulcers. When we have high rates of staffing, we're going to have low rates of pressure ulcers. Well, we know that we can probably make an inference that staffing levels relate to the kind of nursing care that's given, but that's not necessarily the case. Pressure ulcers are complex and there's other things going on. So it might not be as straightforward. So we can say we don't know the directionality of the relationship, so we're doing a correlational study. I should also say that here with a correlational study, we know that we have 2 ratio level variables because that's what's happening with a correlation. We want to look at the level of measurement we've got in cross-sectional studies and prevalence studies. We may have nominal, ordinal, or ratio level variables, depending on what we're measuring and how we're measuring it. But when we look at the statistical tests, what we want to look up is what level of measurement do we have, what kinds of variables, and from that, what sort of test did they use, and do those things correspond? So this is the end of our green right-hand path on that diagram. Now we're going to the blue left-hand path. We're going to switch gears and we're talking about experiments. Ooh, cue mad scientist music. So experiments are considered the highest level of evidence because we can establish causation. We know A causes B. So RCTs, randomized controlled trials, are held up as them and the systematic review are the holy grail of health research. Now, this is open to critique because randomized controlled trials are extremely expensive and hugely labor intensive to conduct. There's also a lot of times where experiments aren't ethical. We saw a lot of horrible experiments in the past and we're trying to do better now. So, they don't always apply. It's not something we can always do. If we are doing a randomized controlled trial, the elements we will see is that we're very strictly managing the context. So we have an intervention group and a control group. The intervention group is the one that is getting the thing, the experimental condition, and the control group is not. So the experimental group might be getting a new medication. The control group is getting placebo. So when we talk about, we can have trials that are blind, double blind. Blind means the person who is assessing these data and the person who is receiving the intervention, are they aware that they are in the experiment or the control group? Because we know Hawthorne effect, placebo effect, regression to the mean, all of these different kinds of effects are out there that could act as confounding variables. So maybe the person feels better because of the placebo effect, not because the medication actually worked. So what we have to do is say, okay, you're getting a bag of stuff, you might be getting a bag of saline, or you might be getting a medication, and you don't know, and the nurse doesn't know, and it's only the person who's administering the study who, put specific numbers on each bag. They know which one you got. But the people who are doing the data collection and implementing this study, they don't know. So sometimes you have a single blind study because if you're doing a behavioral intervention, you can't blind the person. So if you are studying the effect of yoga on chronic pain, you can't blind the person doing the yoga. They have to know that they are expected to show up at the yoga studio and do yoga for an hour 3 times a week. So you can't keep that from them. Maybe you do non-specific stretching versus a specific yoga sequence, but generally with behavioral interventions, you can't blind them. Or you have people that they go to a class, they know they've gone to the class. So in that case, when we talk about blinding, what we're looking at is, did the person who collected and analyzed those data, did they know which person was which? So they should have, a statistical spreadsheets with random numbers and the outcome data, but not know which numbers are people in the experimental group and which numbers are people in the control group. So you can have single blind studies, double blind studies, but ultimately the person who's running your statistical analysis should not know who comes from what group. So typical RCT, we're looking at mothers' voices and white noise on premature infants. So in this case, you'll have moms and babies in NICU, and you might have one group where you say, okay, mom, we want you to read this story close to the incubator every 2 hours for babies so that they hear your voice frequently. And this other group, we want you to just interact normally. You don't have to read the story every 2 hours. And then we'll compare, did the group of babies that heard mom's voice, did they have better outcomes? So that's a kind of classic example of, we've got our control group, our intervention group, and we're looking at, did the intervention make a difference? Now, RCT is incredibly expensive. There are different contextual factors, but generally those are like $250,000 study. So if you're doing especially a medical type of intervention, if it's a behavioral intervention, it might be a bit cheaper, but they're a huge amount of work. So yes, they're the gold standard and we want to use those in many cases. However, it's just not that feasible. And a lot of times we need answers more quickly than what a randomized controlled trial could provide, because they are very, very heavy in terms of the setup and the administration and everything that needs to be done. So instead, we can use experimental designs like a pre-test, post-test. So we're doing an intervention, but maybe an RCT is out of reach. This is especially for educational or behavioral interventions. where maybe it's not feasible to do an RCT. So if we're doing something looking at the effect of simulation for nursing students, well, it's going to be really hard to like split a class in half, give one of them simulation, not the other one, and then they can't talk to each other, which would so-called contaminate the study. Like one person might say this happened in simulation and tell somebody in the control group, and it's just not that feasible. So if we were going to do an RCT in that case, we'd probably compare like Mount Royal University with University of Calgary, or Grant MacEwan University with the University of Alberta, or we will do the entire cohort at the University of Calgary and we measure before and then we measure after. So pre-test, post-test, we measure, we do a thing, we measure again. You might see a third measurement that, okay, immediately after the scores went up, but 3 months later, was the effect retained? So were the scores still high or did it drop off? So a great example of this is mindfulness interventions. Immediately after a mindfulness intervention, people almost always feel better, but we want to see if, 3 months later, were you still doing that mindfulness practice and it felt better, or did you do it for a week and stop? So that's why we might have another measurement further out, especially with a pre-test, post-test design. So quasi-experimental designs, we may have 2 groups, but they are not random. So this is when we are studying things where it is not ethical to create a randomized group. So, people who are pregnant smoking, we can't make them smoke. We can't, make someone drive impaired. We can't give someone influenza to see what happens. So we look at people who out in the world got influenza and compare them with people who did not. So here we have an example of the effects of sleepiness and 12-hour shifts on nurses. So what they would have done here is look at nurses' regular schedules. They wouldn't make the nurses become overtired. They would look at, okay, these are the shift schedules, these are the lines that the nurses are working, and can we measure their cognition and their fatigue and sleepiness based on, where they're at in their shifts, and if they do 2 days, 2 nights, or 2 on, 2 off, 3 on, 3 off, whatever the case may be. So the nurses' schedules are just going to keep happening. They're going to work the regular shifts that they're going to work anyway. But within that, we can set it up as a quasi-experimental design and maybe compare people who are part-time and full-time, or people who do only days and only nights, or something along those lines. So briefly, when we're appraising, we want to say, did we get what we expect here? So we should know enough about the design and enough about the data collection methods and the statistics that if you say, okay, we're going to have a correlational design, I've got like a working model of what that might look like. Then I'm going to compare and say, okay, in this correlational design, did I get what I expect? That's the biggest piece of appraisal, but also you want to say, were the authors clear? Did they clearly state everything they did? Could this be replicated? Do I have enough information here that this study makes sense? And that I could take the method section of this paper, walk over to another university, and do the same thing and get the same results. Were the questions and the hypotheses appropriate? And was all of this well considered? So I'm not going to automatically say this pre-test, post-test study is bad because it's not a randomized controlled trial. I'll say, was a pre-test, post-test a reasonable way to study an educational intervention instead of an RCT? So it's not that, oh, they should have done a better method. We want to say, did this method make sense in this context? Maybe they should have used another one, but have they justified why they did that method? And also, do we consider the strengths and limitations of things? So every study has a limitation. There's no such thing as perfect research. We never have the time, money, and resources for the studies that we want to do. However, we want to make sure that things are generally going according to the plan. And also take into account the realities of things that happen. So if somebody was doing a trial and they had to stop early because of COVID-19, I'm going to give them a pass on that. They had no control over that, so maybe they've ended up with preliminary data instead of outcome data, but that's not their fault. That was a thing that happened in the world that none of us had any control over. However, if they said, well, we got some really good results, so we canceled the study because we wanted to show these great early findings, then I would be a little bit more suspicious. But with all of this, it's having an awareness of what the standard conventional practices are and how does what we see stack up against that. So we do the same thing clinically with patients. We look and say, okay, I know what a normal person breathing without distress looks like. Now that person could be a different race or a different gender, but like generally I know what normal breathing looks like. So when I see somebody who's, I'm thinking, okay, that is not normal. We need to do something about that. And I might not immediately be like, oh, they're having a pulmonary embolism and I can tell because of my X-ray blood clot vision. But we can say, this isn't normal. I need to look into this in more detail. And we can do the same thing with the research study is we know what a normal RCT looks like. So if we see something that, isn't normal, we can look and say, hey, I think we need to investigate this in more detail. So that's when we start asking questions about the quality of research and if we should be applying it to practice. So that is quantitative. You'll see a lot of it in health sciences. And so it's important to have a working knowledge of all of these different ideas, because ultimately our question is, do we apply this research in practice? Can we do that safely with the information we have? And so by understanding the studies, we're able to make that judgment.